All right. Well, this is kind of a fun little thing. We're doing visual diagnosis part 1. I think it's page 257. What we did is we've added 2 half-hour sort of sections here to talk about some fun physical diagnosis things that we might see, or cases that we might see. Billy wrote this one. And these are kind of a kick. These are kind of fun. 5 cases we're going to go through in a half an hour together. And when Billy sort of started the beginning of this, he talks about the concept of file not found, where you walk into, and this happens often with visual things. I'll say derm is my thing, right? You walk into the room. A derm is one of those things where I either know exactly what it is, or I have absolutely no clue what it is. It's like either all or none when it comes to derm. So you walk into a room, you see a physical finding of some sort, or an x-ray of some sort, or an EKG of some sort, and your brain just goes, file not found. You know, that little 404 error, file not found. It's like, geez, I have no idea what this is. In the old days, what we used to have to do, and this is when I moonlit, when I very first started in my career, I was terrified of, what we have to do, we have to know so much stuff. I used to schlep this backpack with every possible textbook known to man, the pediatric textbook, the handbook, the neuro book, everything. Now it's all in here. File not found, get on the internet. It's on your phone. The key is to know that there is something out there. So derm to me now is sort of a match the picture. When I take in my little thing, it's like, okay, what's that rash look like? Ah, that's it. Okay, that's what you have. Because it's fine to do that, because the internet, thank God, has really, really helped us as far as our ability to kind of keep broad in the things that we're supposed to know. So know that this file not found concept is no longer applicable. It's like you can go to the internet and find things. So just know where to go get them. That's what residents are for. It's awesome. All right, let's go to the cases together. Okay, we're going to talk about these cases. The first case there, 35-year-old female, bowled over by her enthusiastic Rottweiler, who weighs 120 pounds. The dog, not the woman, ran straight into her, knocking her down, and ran between her legs. She has a swollen knee, the medial aspect is particularly tender, and she clinically has a large effusion, and it's hard to assess her drawer sign because she is in severe pain. And we have all seen this, right? People with acute knee injuries. If it's really an acute knee injury, it's really hard to do all those Lockmans and clicks and all that. It's just hard because it's really difficult to examine. She limps and can only minimally bear weight, and that is her AP knee x-ray. Okay, so what you're seeing there is her AP knee x-ray. The first question is there an abnormality on that x-ray? Is there something wrong on that film? And what is it? What do you see? Literal lateral chip. What is that little weird literal? No, wait a minute, because she's tender medially, right? On my exam, she's tender medially, but she has that little lateral chip. What the heck is that thing? What's the significance of that? So I've got somebody who's been knocked over, they've got their knee something's happened to their knee. It's swollen, there's something happened to their knee, and they have that weird little lateral chip. That's not normal, that's not a sesamoid bone, that is abnormal. Okay, that should not be there. So what is sort of the clinical significance of having that little lateral chip? Do you know? It's attached to something, and actually to get that thing, and it's actually not that attachment is the problem. To be able to get that fleck of a fracture off, you have to have done a lot of movement of your knee joint to flick off that little fracture. There's a 70 to 80% association of that little chip with an anterior cruciate tear. You see that little chip, and you can't tell on her, right? Her exam, you can't really tell on her. She's too tender. You can't really see if there's actually a cruciate tear. It's too tender. It's too much swelling there. But if you see, that's called a second fracture. Okay, that's a very specific fracture. It's a subtle thing that would be easy to say, oh, kind of cool. I don't know what that is, but fine. It is highly associated with an ACL tear. So know that 75 to 90% of people who have that fracture will also have an ACL tear associated with that injury. And the second fracture is the name of that. If you have an ACL tear and you're able to examine someone, what do you find on your exam? So what's the finding with an ACL tear? So I'm jiggling the leg around. What's the finding that you usually look for when you have an ACL tear? A fusion. And then if I can move the knee around, what moves abnormally? Which sign is that? The drawer sign, and which one? Anterior. So my anterior drawer sign, I pull that knee forward. Especially if I compare it to the other side, it's going to pull, and it's going to have a lot of laxity anteriorly. So I have a second fracture on my film. I know that that's 75 to 90% likely to be associated with an ACL tear. I go back and I find, as I do my anterior drawer sign, an ACL tear. Okay, I find that their anterior drawer is really loose. What if I found that also their posterior drawer sign is loose, which is the next clinical question here. This turns out to be really, really important, and this turns out to be makes you from a good practitioner to a stellar practitioner. So I know Sagan fracture is associated with ACL tear. I know an ACL tear should be an anterior drawer. So far, everything fits. What if I have a posterior drawer too? What happened in that knee? It's an unstable knee. And what is an unstable? Meaning both the anterior and the posterior drawers are out. I've ripped both of those cruciates. What else could I have damaged? Vascular. What that means is that person probably had a knee dislocation, and your only clue to that is that you had that little Sagan fracture, and you were really careful in your exam, and you found the findings that tell you you need to go looking for a vascular injury. This is the kind of thing that really makes you a superlative practitioner. This one little thing, putting all the pieces, it's fun to me. I love this detective work of what we get to do. You get to think all the time, and you get to put things that don't fit together. It's like, why would there be a posterior drawer sign in somebody who should have an anterior cruciate tear? Ooh, that means both are out. And if both are out, that means they probably had a knee dislocation. And if that's the case, I have to worry about the vasculature. And if that's the case, if I do an ABI, I go check my pulses, come do the ABI, and the ABI is normal. Does that rule out a vascular injury? Absolutely not. And if you write that on a chart saying ABI normal, therefore no vascular injury, you're going to miss it a significant proportion of the time, and you are hosed if you miss it. So this is the person. This scenario gets you into the CT angio. Okay, this exact sequence of thoughts, this exact sequence of findings will get you into doing a CT angio to look at the vasculature to the leg, to see if they've actually had a popliteal artery disruption, which is what tends to happen with these knee dislocations. Awesome case. This would be a really great case for you to sort of think it all through and pick up the injury that's more disturbing than the knee itself. That's the vascular injury that would put the foot at risk. So kind of cool. All right, case number 2. This is for the fleas in the room. I did 2 residencies. I did internal medicine first, then saw the light and did a second residency in EM. We spent a lot of time on things like this in my internal medicine residency. A 64-year-old woman with AFib, diabetes, and hypertension presents with rapid ventricular response and shortness of breath. Clinically, she has evidence of heart failure. Although her initial ECG was unremarkable except for rapid AFib, while she's being monitored, the nurse notes a 9-beat run of VTAC and runs to you to tell you this. The subsequent EKG that you get is on that page. So that's the EKG you get handed. The first clinical question Billy throws out there in this is, should immediate amiodarone therapy be initiated? So your nurse says, I saw 9 beats of this thing. I saw 9 beats of this, and you get an EKG that shows that aberrant beat. So you see that sort of perking along there at AFib, perking along, a couple beats there, and then there's this weird beat. It's kind of a right bundle branch block pattern thrown in there. Do you need to start amiodarone? This is a subtle and important clinical question. I want to tell you, first of all, if you have any question whether this was truly ventricular, it came from the ventricle problem, please treat it as such. One of the things about our job is if they're unstable, you're going to shock it. Okay, if something's unstable, if they go into a rhythm that's unstable, you're going to shock it. That's what you do. It's stable or unstable. She's stable right now, and if I have any question of what that was, go ahead and treat it as if it were VTAC. But the subtle finding on this is awesome. So what he's asking in this question of should you start amiodarone is, could there be a benign cause of this? Could this be something that isn't ventricular and scary, that it's a more benign cause like aberrancy? Could this be? The abnormality you see on that EKG, if you look at that, it's perking along, right? AFib, blah, 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 perking along. And then there's that weird long RR interval, right? There's a sort of RRs are variable, but not particularly different. And then there's that one long one. And then there's a short one. And then there's that right bundle branch block pattern beat. That's called Ashman's phenomenon. What that is basically when you have a long RR interval and then a short one, your refractory period is different in the 2 parts of your His-Purkinje bundle. Your left bundle has a shorter refractory period than your right bundle does. And as it depolarizes, and then it depolarizes again really fast, and then it has to regroup. What regroups first is the left, then the right, and you get a right bundle branch block pattern, which is just an aberrant beat. All it is an aberrant beat. And that's called Ashman's phenomenon. It's long, short phenomenon. You only see it in people with AFib. It's a long short. It's called long short. So you see what you'll see. Your clinical clue on this is that as you're looking at an EKG or you're looking at a rhythm strip, you're going to see beat. It's all these little kind of variable beats, and then there's this long thing that should draw your attention, followed by a short RR interval, and then the funny beat. That should draw your attention. They can go on as long as 15 beats of this aberrant thing until it clicks back into just regular AFib with the normal response. So again, if you have any clinical question, you're going to go ahead and treat it as if it were VTAC. But honestly, look closely, and I'll tell you, your monitors in your ERs have they have alert monitors, they have event monitors. So go to your bank of monitors, and what you can do is sort of click on the patient, hit events. It'll pop up little red marks all over their rhythm strip for the time they've been in the ER. And blow them up and take a look. And you may see this long-short phenomenon. It's called Ashman's phenomenon. It's just a refractory difference between the two bundles, and this is a benign condition. Now again, any question, go ahead and treat it. But if you pick up on this, you look like a rock star. Okay, it's like a rock star. Okay, case number 3. 17-year-old male brought to the ED restrained by police with frank psychosis. I'm sure you've never seen this. His vital signs are a blood pressure of 164/104. His heart rate's 127. He has a respiratory rate of 30 and a temp of 99. His pupils are 5 millimeters and reactive, and he tells you, and all he will tell you about drugs is something about butter and something about a rig. Okay, if any of you, I'm going to stop right there. Any of you had anybody come into your ER talking about butter or a rig or dabbing? Because it's coming to an ER near you. So I'll tell you about this in a second. Basically, his friends say he's a normal guy. We've kind of been partying tonight. He's usually a normal guy. He's not usually this crazy. Basically, when you dig around in his pockets, you find that thing in that picture. Okay, it's not the bit of honey that you're looking at. You're actually looking at that thing that looks kind of goopy and a little bit kind of looks like maple syrup, like hardened maple syrup. What is that thing? What the heck is that thing? You give him your blow dart of Haldol. I'm going to patent that. I'm going to patent a blow dart where you can take the wacko person and from across the room, bring him down with Haldol. Better yet, succinylcholine. Just bring him down and then you can tackle him. But you give him Haldol and he says, I've been dabbing. So your clues here are psychosis, something weird in his pocket. He talks about this butter rig dabbing thing. What he has, do you know what he did? How many of you have seen Spice? Somebody who takes Spice. This is Spice on steroids. So Spice is a synthetic marijuana. This is real marijuana that's been basically distilled in a remarkable process. What they do is they take something like a turkey baster and they cram it full of buds, of marijuana buds. And then what they do is they basically distill out the pure THC by filtering it through with something like butane. So they take butane, filter it through this thing, let it soak in there, let the butane come out the bottom, and then you have to get it thicker. So what do? You take butane over fire. Not smart, which tells you one of the things you might see related to this particular drug, which is explosions and burns. So you will see that. It's sort of like you did with crack cocaine back in the day. So that you may see explosions and burns with this. And what they end up with is this paste that gets they kind of scoop it out. It's really thick. It looks like honey. Okay, that's why they call it things like butter or honey. Looks like honey. It's basically hash oil. It's called butane hash oil. And this basically, they either vape it in those little vape things, or they smoke it. And what it gives you is basically an incredible high, a THC high. That what they end up with is psychosis sometimes, agitated sometimes, burns, and they get terrible judgment if they're using this, because that's a ton of THC all at once. So if they go out and drive or they decide to go climbing on buildings, they'll do stupid things. So they end up with trauma as a result. So burns, trauma, and wacko. Okay, it doesn't usually cause cardiovascular problems. It doesn't usually cause pulmonary problems. It just makes you completely wacky. So bad judgment things happen, and psychosis happens. So all the things that we have to do to kind of calm somebody down with this. They may, if they use it a lot, they may have problems with withdrawal. I'll tell you, we're seeing, I don't know about you guys, but now that marijuana is becoming more sort of legalized, et cetera, my husband's from Colorado, and we go back there, and everybody smokes. I mean, you go everywhere, it's like everywhere. We're seeing a lot of marijuana withdrawal syndrome, where people are coming and barfing their brains out. Your clinical, and we're finding a lot of these people that come in with refractory vomiting, and nobody ever asks them the question of, do you smoke a lot of pot? Because if they smoke a lot of pot and they quit, they barf, and they'll barf, and they'll barf, and they'll barf. And they're refractory to almost everything you treat them with. And what works is a hot shower. Or what turns out probably works is capsaicin cream. the capsaicin, the basically pepper spray in a cream. There's something about the sort of chemical response that you have to something hot, and that includes spicy hot on your skin or temperature hot on your skin, decreases the vomiting that goes with it. So this basically, it's cannabinoid withdrawal syndrome is a cyclical vomiting syndrome that is really hard to treat. And your clue will be someone will say, God, I've been barfing all the time, but I feel so much better when I take a hot shower. Aha. Do you smoke a lot of marijuana? You're going to save people mega workups with this by actually honing down on what's really wrong with them. So this is one version of basically concentrated THC. All right, case number 4. A 45-year-old nurse saw an NP at Walmart, was referred to the ER for removal of a wart on her finger that had been there for over a year. Radiographs are negative. It really doesn't bug her a whole lot. It just kind of is unsightly. She doesn't really like it. And she was sent to you to have that taken care of. What is that thing in that picture? Anybody have any idea what that is? If you would like to see it in real life, I will offer up my right index finger. And no, it is not herpes. Everyone says, oh, that looks like Whitlow. That is not herpes Whitlow. This is not herpes Whitlow. So this basically what this is a dermoid cyst, or excuse me, a ganglion cyst. It's from the joint. It has a little teeny tiny stalk that comes out of the joint, and then it kind of blooms near the surface. And it's full of synovial fluid. This thing, it's squishy, okay? It's not painful. It's not red. Just kind of sits there. And the problem with this thing is you can't fix it. So the Bible version of breaking your ganglion cyst that your grandma used to do. If you had a ganglion, they'd slam your hand on the table and break your ganglion cyst. It doesn't work. And in fact, surgery doesn't work very well. You can't aspirate it just comes right back because it's synovial fluid. It's being produced all the time. And if you try to cut it out, it ends up with more complications than help. So you're kind of stuck with this unsightly thing. It is what it is. I've taken up ceramics, and I actually use it now. When I pull up a ceramic thing, I can actually turn my finger a little bit, and I get this wonderful ridge up the side of my pot that I'm making. It's really cool. It's like my signature pot now. I just love it. It's great. So if you would like to see it, come on up. I will offer up my finger as an education thing. But that is it's a benign condition. It's kind of unfortunate. You can't do much for it, but it's basically like a ganglion. It comes from the joint. All right, the last case. 5-year-old unvaccinated boy, religious reasons are offered, presents with his face you see, with the picture you see there, and a temperature of 100 degrees. The redness developed over the last 24 hours, and he can see when he opens his eye, pardon me, but it hurts a lot when he looks around, and his full EOMs can't be documented because he really cries, and he's uncooperative because it hurts him. There's no history of trauma, no scrapes, no lacerations, nothing. And what you see is a little crusting around his nose, around his nares, but that's all you see. Around his left nares. So that's what he looks like. That picture is what he looks like. The only thing on exam is that little low-grain temperature and some little crustiness around his nose. What is the significance of the fact that it hurts when he moves his eye? Orbital cellulitis. The clinical differentiator between periorbital and orbital cellulitis is pain on moving the eye. And that's because in the orbit now, your extraocular muscles are irritated or actually truly infected. And so when you move your eye around, it's uncomfortable. That takes it from, well, you got a little bit of a skin infection to it. Oh my God, we have to do something about this infection. Your orbit is a closed space. It's really close to your brain, so the bad stuff is right behind there. So it's a very significant clinical finding. It means there's an infection behind the eye. What is your imaging procedure of choice with this? CT, how? You're going to with or without IV contrast? With. It's actually quite important to do this with. You will find certain findings that are suggestive on plain CT without contrast. If for some reason you absolutely couldn't use it, you'll see some of the swelling of the extraocular muscles. You might see some fullness in there. But it helps you determine how much of this is truly active infection and how much of this is just edema. So it turns out that is very important to get a CT with IV contrast. The diagnosis is orbital cellulitis, and how do you treat it? There's 2 things we have to do here, right? One is we need to take care of the infection. What organisms do you cover if you're trying to treat orbital cellulitis? What organisms do you cover? So H-flu in this kid, because he's unvaccinated, right? We don't see H-flu. I'll tell you one of the reasons we don't see orbital cellulitis as much as we used to. It's often H-flu. But we see kids that are vaccinated now. So we don't see as much of this as we did even 20 years ago. So H-flu in this kid, because he's unvaccinated, definitely cover. But in most kids now, what kind of organisms, what organisms cause this? Sinus stuff. So you need to cover sinus stuff. And in our era, as you just heard in the last hour or last half hour, we also need to cover MRSA. So what you're going to be covering in this kid is Haemophilus type B. You're going to be covering MRSA, and you're going to be covering sinus bugs. So you're using pretty broad and high doses. So this is the higher dose ceftriaxone plus Vanco. This is the higher dose deal for this, because it's a pretty serious infection, and it's akin to meningitis. As far as getting that close to the brain, you need higher doses. The other arm of treatment is surgery. So it turns out that anywhere between, the low I've ever seen in the literature is 15%, but it's more like 50 to 60% of people with this disease, with this infection, need to have it basically opened. They need to be decompressed in the orbit. And there are certain findings that will help you be more aware that this person may need to go to the OR. If they have restricted extraocular movements, both from discomfort or from true just too much swelling, if it really hurts too much to move, they often need to go to the OR. Proptosis, absolutely. The best way to look for proptosis, this kid's got a swollen eyelid, right? How do you tell if they have proptosis? Stand so that you're looking so if I'm standing looking down at the patient this way, I'm looking from the top of their head. Okay, I'm not looking facing them because it all looks asymmetric. It's weird. Look from the top of their head. So you're looking down this way, and look actually at where the corneas are. And you'll see proptosis much better that way. The CT scan will do it for you too. You can measure it on CT scan. So proptosis is another indicator. Increased intraocular pressures, which is interesting. How often do you check this? You don't in this, but it's just like somebody who has a retroorbital hematoma. If they have increased intraocular pressures, they need to have that thing decompressed. And it turns out the older you are, the more likely you are going to need to have that decompressed. So a low of about 15% to a high in one study of 95% need to have that decompressed.